Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Gavin Magaki. He is a healthcare executive, and today's Kevin MD article is Advancing Drug Discount Program Starts with Collaboration and Clarity. Gavin, welcome to the show.
Thank you very much, Kevin. Glad to be here. Happy to be on board.
All right, so just briefly share your story and then jump right into your Kevin MD article.
Sure. So I graduated from Wingate University School of Pharmacy, completed a 2-year health system pharmacy administration residency through the University of North Carolina and Wake Forest Baptist Health. And during that residency is where I discovered my passion for healthcare policy and kind of stayed on as the director of their medication control and compliance while I was there. Had various responsibilities, including managing controlled substances, the procurement process for pharmaceuticals, and this little unknown program at that time, which was the 340B drug program. So after several years in that role, I leaned into my other passion, which is education, and I went to work for Apexis, which is the HRSA selected 340B prime vendor. And so as director of 340B policy and compliance support there, I really provided HRSA aligned education nationwide to all stakeholders about the 340B drug program. So all of that positioned myself to now I am a senior director in external affairs and policy at Calderos, where I get to bring all that operational knowledge and experience here to help support our initiatives to solve some of the largest problems that are out there facing the U.S. healthcare system. So that's a little bit about me. So maybe talking about my article and kind of how it came together, it might be appropriate to really quickly put in a 30 to 60 second primer on drug discounts and 340B. So to level set, as a condition for having their products covered by CMS, manufacturers have to agree to sell their products at a substantial discount to both Medicaid and safety net providers.
Okay.
Now, for Medicaid as a payer, this is achieved through the Medicaid Drug Rebate Program, also known as MDRP. Providers provide care to Medicaid patients, and then the state will actually pay for those services. And then every quarter, Medicaid then sends the manufacturers an invoice for the number of units that its beneficiaries have received. And so the manufacturers will then provide that discount as a claims-based rebate. On the other side, you have the safety net providers. And so this is achieved through the 340B drug pricing program. Currently, the most popular way that this discount is provided is by selling a full package with an on-invoice discount to a provider. The expectation is that these providers who are also known as covered entities, will give 340B purchased inventory only to eligible patients.
Okay.
And so where this all gets confusing is when a Medicaid patient is treated by a safety net provider. So in that case, what do you do there? HHS says the manufacturer is only to provide one of the discounts, but which one? So as your listeners, if a provider uses a 340B purchased med, they need to notify Medicaid so that the Medicaid doesn't seek the rebate. So that's kind of the primer and how that comes together. So my article, the article's roots actually stem from a fairly basic question, which is if we implement solutions to address a problem and in a system, and then we measure the impacts and the effects of our efforts, and the results we have either don't change or maybe they get worse, should we really continue the status quo?
Right.
Or do we need to acknowledge that the current system isn't working and we need to try something different, right? So as clinicians, very similar, right? If we're trying to treat or help our patients control and manage their type 2 diabetes medications, and we prescribe them metformin, right, to try to lower their A1C, and instead either it stays the same or it gets worse, right? It gets higher. At some point, we're going to want to change therapies, and so the question is really how long does it take for us to do that? So it's very similar here. So despite education efforts and third parties that are actually trying to help optimize various processes, non-compliance in this 340B and Medicaid drug rebate space just continues to be an issue. And it's a very large issue. I think in 2023, the 340B program actually reached 66 $1.66 billion. And it represents the second largest federal drug discount program after Medicare Part D. And so each year, HRSA, the Health Resources Service Administration, which is a division of HHS, they are responsible for 340B oversight, and they conduct audits, 200 audits of covered entities.
Mhm.
And surprisingly, since 2013, only a third of those providers each year receive a clean bill of health, if you will, no audit findings. So putting that in perspective, for fiscal year 2022, which was kind of the last set of complete data that we have, 140 out of 199 CEs had some sort of compliance finding noted by HRSA. So this is a problem that has been going on for a long time. And at some point, we need to make the decision, what can we do to potentially change this? And so the importance, of course, is when these funds, when there's non-compliance in the space, that means that there are misallocated funds moving around, or in some cases, the funds aren't moving at all.
Yeah.
As an example, manufacturers are presented with that Medicaid rebate invoice. If they deduce or they determine that the products used were 340B, purchased under the 340B program, they'll dispute those charges. And so then you end up with dollars that are tied up that are not actually going to the respective parties, and they're not accessible to the state and the federal programs. So this really begs to the question of what's going on. What is the driver for non-compliance? And the one that I think listeners that have had some, and providers that have listened to the podcast, they certainly know they have limited time, right?
Yeah.
That's why you have these short podcasts. It's so they have limited time and FTE resources, and so they have to deploy them where they're most effective and they can be. So they struggle with this sometimes. And also systems are disjointed. They're not aligned. As is often the case, systems are kind of built kind of piecemeal by piecemeal over years. And the 340B ecosystem is no different. It came about back in the early 90s, and systems have been building and building and building. And so you end up with a collection of cobbled together systems that just do not integrate and work well together. And so the times have changed, right? When we look at 340B program, it was, like I said, it was enacted in 1990, I think 92, 94 area.
Okay.
And there have been major advantages in healthcare. I mean, I still remember manually entering in paper orders as a pharmacist back then. So, but there's been little changes in the 340B architecture and 340B operations. So that's really kind of the impetus behind the article, is to really highlight that there are changes that are needed. We really need to drive towards improving the systems and making things more transparent so that we can really get to the issues of taking care of our patients.
Sure. So you mentioned a minority of clinician offices are compliant. You said like 1/3. Tell us about some of the downstream effects, about how that affects patients down the road, because only a minority is compliant with the 340B regulations.
Yeah, so the providers, the clinicians, I don't know many that actually got out there and wanted to be all about the 340B drug program. And in Medicaid, it wasn't really what they're calling per se. It happens to be that with no margin, no mission, right? And so they're really trying to do what they can to be compliant. But when you have to conform to HHS, has both HRSA and CMS underneath of it, and they've got different various agencies, areas of agencies and authorities. So trying to really comply with both, even though they don't speak the same languages, it's really challenging and very hard. And despite their best efforts, because we've certainly learned that most of the non-compliance is not intentional, right? Providers are trying very hard, but with their limited staffing resources, it's such a challenge. And then you add to this the time expense of working with manufacturers to try to resolve discrepancies and going back and forth. It's very time consuming, right? It often requires these providers to take a Medicaid claim that is often de-identified and try to back into and find where it was given to a patient during a specific encounter. And then you have to try and determine, we haven't exactly talked about the difference between the 340B program being a package based where you buy the product at 340B and you've got a bottle.
Hmm.
Now you have to try to track where those pills from that bottle came from. So you have to back into
Yeah.
this. It's a lot of effort, and it shouldn't be, and it doesn't have to be this hard. And now, given the current environment in which we live.
So tell us about some of the paths forward in terms of increasing that compliance rate.
Right. So really what the path forward, at least in our opinion, is to first align the systems. And so as we kind of pointed out, the 340B drug program is a package-based system, whereas all of the most of the major Medicaid, the new IRA and
Hmm.
max fair price, when it comes out, those discounts and rebates are given on a unit-based level. So the amount of drugs or product that's given to a patient, and it's based off of that encounter data. So moving into a scenario where you have the 340B discount also being given on a unit level
Hmm.
based off of encounter data is really the first step. So standardizing the process is making sure that you're comparing apples to apples is really an important first step in this process.
Give us a sense of some of the resources it takes in order to be compliant. And you alluded to this earlier. You gave us some scenarios, but for a typical small physician practice, tell us the amount of resources and time it will take in order to meet compliance. Just give me a sense as a practicing physician.
So it starts with your FTEs and how many FTEs you have that you can allocate to the program. And that really kind of depends on how large the practices are. If it's a small physician practice, a provider, maybe a clinic that's an FQHC, for example, in a very small scope and doesn't really have any retail pharmacy presence, very simple for typically one person to kind of
Okay.
handle that. When you start to scope out, which many of the safety net providers have done to take care of more patients, you end up with multiple clinics. If you're a hospital, you have multiple locations, child sites that exist out there. And really you start to see this increased demand on FTE resources to essentially you're going out and they're also going to be engaged in purchasing and working with third-party administrators and software systems to track the dispenses as well as the purchases of these products. And so now you're adding the cost of these platforms as well. And so it can get pretty costly right off the bat
Hmm.
when they start to partner with contract pharmacies. And so that's when you end up with a provider who may not have their own retail pharmacy, but yet they want to help the patients that they're treating get access. And we know that having medications in hand, right, like is very important. So when providers establish these partnerships with retail pharmacies out there, that's an added expense because they're going to, of course, going to be paying the large big box stores to help them dispense products to their patients in this contract pharmacy arrangements. And so you really end up, it can get as quite large or it can be very simple, but either way, there's definitely a huge impact from a compliance or a risk as you get large. The larger you get, the increased risk comes with it of being non-compliant.
And in terms of the penalties of being non-compliant, tell us about those.
Yeah, so a lot of folks will worry about being non-compliant. I know way back when a couple of my pharmacy directors would always worry about being put in an orange jumpsuit. They said orange is
Okay.
not their color. But luckily, there are no criminal penalties associated with this. So most of the time, the penalties that a covered entity might have to pay back to a manufacturer is essentially just the dollars that essentially have been redirected.
Hmm.
So if you have a product that you mistakenly don't identify as 340B and a Medicaid goes and seeks a rebate for it, I mean, you think of like your Harvonis out there or your large, your $1,000 worth of drugs, tens of thousands of dollars worth of drugs. If you have a systemic problem where those aren't getting captured correctly in your systems, you could be looking at millions of dollars
Mhm.
of kind of reallotments and reallocations that you have to go back and try to figure out where those monies are going to come from. And so it can really disrupt the budget cycles you can imagine for your corporate executives and in a lot of your large hospital systems.
We're talking to Gavin Mugaki. He's a healthcare executive. Today's Kevin MD article is Advancing Drug Discount Program Starts with Collaboration and Clarity. Gavin, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Oh yeah, fantastic. I'll tell you the really the take home message, the first is it is it's way past time to align the 340B drug purchasing program with the other drug discount programs that are out there. Moving towards a unit-based encounter supported program will standardize data points across the board, allow for more efficient communications, quicker and faster, more accurate, and apples to apples comparison to the data. The second, of course, would be to create the best health care outcomes. We have to look at the data and be able to look at that data and use it to guide decisions. It's important to acknowledge that the feelings that are out there that are associated with change, there's the fear, the anxiety, uncertainty, it's all out there. But we should not over-index on those feelings. We saw this years ago when we really started leaning into reporting, healthcare safety events, right? And how beneficial it was to actually acknowledge, yes, there's some fear, but in the totality, you're getting a better effect. And finally, just let's continue to have these discussions.
Mhm.
If folks would like to talk about these concerns, certainly I'd love to hear about them. We're all working towards improving healthcare outcomes for ourselves and our patients.
Gavin, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you so much for having me.